So I'm going to go over how to refer patients to open and affordable oral surgery. So the main emphasis of this video is how to make the transition from the general practitioner to the oral surgeon just as seamless as possible for the patient. And so we've prepared this section in the doctor manual, and both the fronts and especially the GP doctors should review this, and especially this video. So the first thing that we're trying to do with oral surgeon is to make sure that they're actually doing as many procedures as possible instead of doing a lot of consultations. Sometimes general practitioners, especially newer general practitioners, like to refer everything that they don't know how to do to the oral surgeon and have the oral surgeon figure that out. That's really a situation sometimes with pathology, and especially when you're referring to an outside oral surgeon. But since the oral surgeon comes in and is mostly dedicated to placing implants and to extracting wisdom teeth, it's important that the general practitioners within open and affordable are versed on how much bone is needed to place an implant and what are the parameters around extracting wisdom teeth. So we should really be trying to reduce the amount of OS consultations, as that sometimes takes time from the oral surgeon in actually getting procedures done. Now, if you truly have a question on if it's able to be done, I would make your owner doctor the first one aware of the potential case, and if they think that it's a good case for oral surgery extraction or an implant. And then after that, and after you've kind of reviewed this video, and once you've become more experienced, you will be able to refer directly to the oral surgeon, the open and affordable oral surgeon, more effectively. So really, again, during your career, try to reduce the amount of consultations, because really that's what you're doing at the GP visit, and you should be scheduling more actual surgeries with the oral surgeon. You can also reach out to the oral surgeon through Signal, and you can ask them questions that way so that they can reduce consultation appointments during their oral surgery day. There are some procedures with oral surgery that really aren't appropriate for the open and affordable oral surgeon. Because they're only at the office one time a month, some procedures, especially pathology, are better if the patient is seen at a dedicated oral surgeon's office. So if you see something that is concerning, you might want to text it out to the oral surgeon, see if that's something that they want to address. But most likely the pathology needs to be addressed at a dedicated oral surgeon's office, okay? This can also be used, or a dedicated oral surgeon or oral surgery office also should mostly be used for those that have behavioral problems or those with special needs, because again, it isn't really a hospital setting, and some of those types of appointments might be better at a dedicated oral surgeon's. One thing that is important is that we're scheduling the correct oral surgery appointment type. So the general practitioner will be scheduling the oral surgery visit and using the appropriate appointment type right there in the operatory with the patient. Or the front, if they're receiving a call, can schedule onto the oral surgery appointment or onto the oral surgery day, as long as they use the correct appointment type, and especially that the patient has already seen the general practitioner. So for example, if a patient calls and they've never been seen at the office before, and they are not being referred in from an external general practitioner's office, then we would need to have them go through the general practitioner first so that they can diagnose the issue, and then they would refer to the oral surgeon, the open and affordable oral surgeon. If they are being referred by an outside general practitioner, then we would simply just need to have the oral surgery referral form filled out, and that can be a paper form or an electronic form, and then they can be seen directly by the oral surgeon. So obviously the appointment types are queued up here when we go ahead and select patients. We can see that the oral surgeon appointment types are down here. So we have the consultation, any sedation that is needed, full mouth extraction, implant surgery with 1 implant, implant surgery with 2 to 4 implants, non-extraction surgeries. This would be soft tissue lesions, mucoseals, things like that. Wisdom teeth, 1 wisdom tooth, 2 to 3 wisdom teeth, or 4 wisdom teeth. So if someone is getting 4 wisdom teeth out with sedation, it's important that we use this sedation because that's a kind of a whole nother setup for the oral surgeon, okay? We will go over that the oral surgery day will be designated by the oral surgeon or oral surgery coordinator, and they will be putting blocks at the beginning and end of the day. And you do not have to place the appointment at the exact appointment type or at the, at the right appointment time, because really all the oral surgery day is placeholders for appointments. When the oral surgery coordinator starts doing their confirmation calls, they will button up the time and make sure that the patient knows exactly when it is. So not getting too far ahead of myself here. Let's, so we'll go ahead and continue back to this portion here. So we'll make sure that when we place the appointment that we do put some information into the appointment note. So, for example, if I'm scheduling this person for sedation, I'll go ahead and put here extraction sedation, and we'll say here extract 1/16/17/32. We'll also put patient prefers mornings, and then I'll go ahead and put my initials here, okay? And let's say that we have multiple patients that are being scheduled for that day. We can put it here in the afternoon. It does not matter if it's in the afternoon or the morning, because when the confirmation calls are being completed, the oral surgery coordinator will simply drag all of them over to the side, call all of them, and then start building the schedule from all of the available appointments that the general practitioner has placed on that day. So the time will not be given to the patients. The verbiage usually is, so let's get you scheduled for that day. I can give you an appointment card. It's kind of preferred to not give the appointment card because there's a lot of confusion when a patient receives an appointment card and a time is written down. Then they think that that day and that time is when they're going to have their surgery. The verbiage usually is, I'm going to go ahead and get you scheduled for that day. The day is guaranteed, but the time will be given to you by the oral surgery coordinator when she calls 2 weeks in advance of your appointment. We usually are giving out the appointment, the oral surgery coordinator's business card at that time, so that if they do have any questions about their oral surgery, they can call that number directly. In fact, after the referral has been completed, really the main point of contact is the oral surgery coordinator, not the general practitioner front. Now, they can definitely call back and talk with the general practitioner, but it's best to talk with the oral surgery coordinator or secondarily with the general practitioner. So again, we'll go ahead and put our initials, put any information there, and we'll give out the oral surgery business card. Now, we'll go over this a little bit later, but the oral surgery coordinator will do several confirmation calls and go over pre-op instructions, go over the amount that's going to be expected out of pocket by the patient. So that information will be given to them later on. Another thing too is if you are treatment planning for oral surgery procedures that will be done with the oral surgeon, it's best to know the approximate amounts that the oral surgeon charges for those procedures, and then either queue up those prices inside of Eaglesoft or just leave those codes or those treatments off of your general practitioner treatment plan so that you don't start giving confusion to the patient. So, for example, if I were treatment planning extractions on this patient, we'll wait for the chart to come up here. I am super fine to go ahead and treatment plan, let's say full bony extractions, but I would want to either overwrite the GP fees or go ahead and just not include them on the treatment plan. So we'll see if that comes up here. Again, we'll go ahead and give out the oral surgery business card, and then we'll go ahead and fill in the provider referral form, okay? So the provider referral form is found under doctors and then refer to us, okay? And you'll see this page queue up, okay? So with this page, obviously you're going to put in the patient name, and you're usually copying that right off of Eaglesoft or off of the routing sheet. The patient's phone number, you're going to want to confirm the phone number that they are using, or the phone number that is best to call the patient at the time of oral surgery. And then we'll just go back to that. And then the referring doctor. So for example, if this was Dr. Stott and you're coming from an open affordable practice in Bennett, it's probably best to just kind of put it like that. And then you'll put the office phone number, and then you'll put the office at which they're going to be seen. So if it's Bennett, Colorado, you'll go ahead and put that, and then the oral surgery type. Now, obviously, there's the ability of you to put what exactly should be happening. And so if, for example, if we're going to be doing extractions on 1, 17, 32, and 16, you'll just go ahead and place that there. Obviously we can do extractions, we can do implants. The oral surgeon can also do expose and bonds of impacted teeth. Pathology, again, we had talked about mostly having those go out to dedicated oral surgeons, but if you've talked with the oral surgeon and they're okay with looking at something, you can look at pathology. You also need to check on request sedation. So for example, if we are looking at extracting all 4 wisdom teeth and the patient does request sedation, you'll go ahead and check there. And if there's any other type of procedures, you can go ahead and click here, okay? With Colorado Medicaid, it's important that the GP communicates to the oral surgeon which teeth are giving the patient problems. Now you can, if there's supernumerary teeth, you can go ahead and click on other, but the oral surgeon is usually only able to get paid from Colorado Medicaid if the patient has reported pain. So this is a mechanism to allow the general practitioner to communicate to the oral surgeon which teeth the patient has complained about. It is possible if, let's say that the patient has complained about pain on 3 of these teeth, yet they do want to get all 4 of them out, then it might be appropriate to put here, discussed with patient, possible out of pocket for number 32, meaning they don't report pain on it, but they do want to get it taken out, so they might be requested to pay the full amount for that tooth, okay? And then down here, there is the ability for us to attach either the new patient form or the panoramic x-ray. This is especially true for when we are referring, let's say that we're an office that we do not have an oral surgery day, or the patient wants to be seen sooner. Then what we could do is we could refer them to another open and affordable office, and we would need to attach both the new patient forms and the most recent diagnostic x-ray, potentially being the panoramic x-ray. And so another way to access where the oral surgeon is going to be is through the open and affordable website. If we go to office access, you are able to see the specialist schedule here, and it will show you the closest days that the oral surgeon will be at different offices, so that you can refer to the best office for the patient. Okay, so once this is submitted, that referral will then be sent to the appropriate office, and this is what it'll look like. It'll come in the office's email, and then that referral is then transferred by the front office to the SmartDoc. So how does the front do this? If you're a front, this is how you would do this. You would go into the Gmail, and when you get this referral, you're going to print it as a PDF. So let's say that I'm doing this particular referral. So I can go ahead and click on, for example, I'll go ahead and you could even do it from here. We can go click on print, and then as far as our destination, we would go save as PDF, and then we could save it, let's say, to our desktop, and then import it to that particular patient's SmartDoc. And obviously we would rename that to OS referral. And so that will allow the oral surgery coordinator to see exactly what the referral was for. Okay, so that's the front office's responsibility, to monitor those referrals that are coming in and to save them into the particular patient's SmartDoc. So again, back to treatment planning here from the GP. So for example, we'll just do one tooth here. Let's say that we have some fillings that we're going to do. Okay, and I'll go ahead and just make a quick change here. Okay, so if we have some fillings that we're going to do, and then we're also going to do, let's say, a full bony extraction here, we could either accept these fees, or we can overwrite them to be the oral surgery fees. Okay, so when we do come up with the treatment plan, we could just say, for example, we're going to phase all of the GP fees here, and then we're going to do the oral surgery fee here. And then when we go to access this, obviously the oral surgery fee is going to be down here, okay? And so the verbiage with the patient will be, so, you know, obviously this fee here is the oral surgery estimate. The oral surgery coordinator will button up the exact amount that is due out of pocket for you 2 weeks before your appointment, so you can get prepared for that. Obviously, the other thing to do, you know, and this might be more efficient, is when you go ahead and make the treatment plan, to just go ahead and delete it from the current plan. Go ahead and process that. And then when you go to your treatment plan, you'll obviously not have any of the oral surgery codes on there. So that might be more efficient with the patient. But again, the major issue has been in the past is patients getting fees with general practitioner prices, patients being quoted fees by the general practitioner when they're not actually accurate. And so it's really important that you create just as smooth of a ramp from general practitioner to the oral surgeon as possible, defaulting that the oral surgery coordinator knows more about the fees and the final code that's going to be used, if it's a partial or if it's a full bony, because the oral surgery team coordinates with the oral surgeon to make sure that those codes are all complete and accurate. Okay, so again, important to make sure that you've watched this video on that. So again, here's our oral surgery prices for 2023. So it's good to have that kind of at the top of your head. Okay. Now, some considerations for Colorado Medicaid that, and we had talked a bit about this on the referral form, is it's important that we designate that we have reports paying on section filled out. It just helps. A lot of times what will happen is the GP will refer to the oral surgeon. The oral surgeon will kind of lead into saying, hey, we do need to make sure that you've been in paying for Medicaid to pay for this patient. Does that tooth hurt? And even though the patient had gone in through the GP and said, yeah, I want to get this wisdom tooth out, it's been hurting, and even with the oral surgeon kind of leading the patient on, the patient will say, no, it doesn't hurt. And then the oral surgeon is in a predicament. Well, you had said that it hurt, but now you're not. So unfortunately, unless you're willing to pay out of pocket, I can't take the tooth out. And so there have been several patients that have had to be rescheduled just because of that miscommunication. So if on the provider referral form it says patient reports pain on that, it just allows the oral surgeon to say, yep, there's been pain that's been reported on it by the general practitioner from the patient. I'm good to go ahead and take those teeth out. Okay. On the sedation, so what has happened is we have tried to get reimbursed by Colorado Medicaid for the sedation, but unfortunately we just are not successful in doing that. And there's a lot of confusion from the patients who like to call up Colorado Medicaid and say, hey, I am going to be sedated, and the Open and Affordable Dental is saying that they will not take your fee for the, or they will not, or they're going to charge me to be sedated. And a Colorado Medicaid representative will say, or a DentaQuest representative will say, nope, I'm seeing that that's a covered procedure, it should be covered. The issue with that is, and this is explained both on the frequently asked questions and in the section, is that although Colorado Medicaid says that it's a covered procedure, they also have a stipulation that it has to be a medical necessity. So what happens is the only types of patients that really have a medical necessity of being sedated are those with severe behavioral issues or those that are autistic. So if those two things are, if those two conditions have been met, then yes, you do have a medical necessity of being sedated, but it's best that you are sedated in a hospital setting. So for those types of patients, again, we're going to get them referred to a hospital setting, and Medicaid will pay for it out of, will pay for the procedure, okay, for the sedation. So unfortunately, because the other patients don't qualify for the medical necessity, Colorado Medicaid has that as a non-covered procedure. So because it's a non-covered procedure, then we're able to charge what the oral surgeon charges for all patients, which is the $600, okay? So it's good to read this section through, both in the doctor manual and also in the frequently asked questions. It's basically the same verbiage here, so that you can be versed on why they would have to be sedated. And it might not be a bad idea for you to go ahead and kind of queue up the patients that if costs are an issue, that they go ahead and talk it through if they really need to be sedated, and maybe encourage them to not be sedated if they're not super apprehensive. Again, being apprehensive for the appointment is not a medical necessity to be sedated. So again, on the sedation costs are $600 to sedate the patient. Now, if they do have regular insurance that covers sedation, again, the charge is also, just like any other procedure, is these charges minus what your insurance pays, okay, to give a ballpark estimate. So sedation would be $600. And the issue with a lot of insurances is they charge less than that, or they reimburse less than that. And for our oral surgeon, they do not feel that the risk can be justified in taking less than $600, because they have to sedate the patient, they have to do the surgery, they have to monitor the patient, and so the $600 charge is very important. Okay, so if you take a look at this, sedation, you can see it usually doesn't queue up minus what your insurance pays, because we're really trying to queue the patient up to understand that there will be a $600 charge for the sedation. So again, on the treatment plan verbiage, you're going to communicate that all of these oral surgery procedures are done by an oral surgeon who's been trained to make sure that it's as painless and as efficient as possible. And then as far as the implants go, we have included the implant exploding code on the odontogram, which allows you to treatment plan an entire tooth coming out with the surgical extraction and all of the codes that the oral surgeon potentially might use. So if I click on implant here, obviously it's going to queue up the surgical extraction. It's going to queue up the bone graft, the placement of the implant, the custom abutment, the abutment supported crown, and the guided tissue membrane. So it's important to try to use that exploding code when at all possible, just so that you queue up the patient to understand what the total procedure is going to cost, okay? So on the different extraction types, it's important to look at these, not only look at these x-rays, but kind of talk with the oral surgeon and or the oral surgery coordinator to calibrate what exactly is a simple extraction, what is a surgical extraction, and what a partial bony extraction and a full bony extraction is, okay? So if we look at surgical extractions, and if you think about what oral surgeons do compared to general practitioners, it's usually very rare that an oral surgeon is going to do a simple extraction. The only time that they maybe are going to do a simple extraction is if you have a super apprehensive patient that's willing to pay for sedation, and we're taking out potentially like a lower anterior tooth, okay? That would be the only time that a oral surgeon is going to do a simple extraction. Almost all extractions done by the oral surgeon are going to be surgical extractions or greater. So a surgical extraction is an extraction where you cannot see radiographically any portion of the clinical crown being covered by bone, okay? So, and that's the definition of a surgical extraction, especially with an oral surgeon, because an oral surgeon is most likely going to lay a flap on every single tooth and is going to usually remove bone. So the baseline for an oral surgeon is a surgical extraction. The definition of a partial bony extraction is any extraction where between 1% and 50% of the clinical crown is covered by bone. So we've given you some examples here, and you can see here that sometimes it looks like the ramus is covering the distal portion of the tooth. Again, radiographically, if any portion of the x-ray shows that a portion of the clinical crown is being covered up to 50%, that is considered a partial bony extraction, okay? On full bony extractions, the definition is if it is greater than 50%, all the way up to 100% of the tooth is covered by bone, that is considered a full bony extraction. So again, if you take a look at these x-rays here, those are all full bony extractions. Sometimes a portion of the adjacent tooth covers the tooth that's going to be extracted. That would be considered inside of the percentage that the clinical crown is being covered, okay? We talked about pathology, that most pathology is going to be referred out to a dedicated oral surgery office, and that allows for immediate follow-up in case it does turn into cancer, or if they have needs to access a hospital for the severe cases, okay? One thing that we've seen over the years is some adults being referred for oral surgery where really we should try to maybe leave the tooth or monitor the tooth. So for example, this was, I believe, a 56-year-old male. They had their wisdom teeth planned to be extracted, and if you take a look, especially on 32, obviously that's covered by bone, so usually not a whole lot of reason for that to be indicated for an extraction. Usually we're going to need to write that out to the end of that patient's life. There could be a little bit of justification for the extraction of this number 17. Maybe there is a cyst around the tooth. You can make a case for that, but on 32, I don't see any pathology there, okay? So if the patient is over 40 years old and there is bone present around the clinical crown, 100%, then usually we're going to try to write that out. If they're less than 40, or if a portion of the clinical crown is sticking out through the gums, then it's indicated to get that tooth out, okay? So again, review all of these x-rays and basically get calibrated to what is expected on the oral surgery side, what types of procedures to refer out, and it'll make the transition quite a lot better. So on the oral surgery versus general practitioner responsibilities, this is mostly for the owner doctors. So the general practitioner or the general practitioner office is going to provide one front office, and then they need to make sure that they have 2 statums or a larger autoclave available for the oral surgeon, and then we need to have 3 operatories available. The oral surgeon will provide 2 assistants, and then they will do all of the insurance verification and the pre-auths needed, and they will also provide the x-ray, or excuse me, the confirmation calls, and they will also import panoramic x-rays and whatever's needed if it's referred from another office. Although we should be mostly sending those through the refer to us or the digital form. So there should be a lot less x-rays that are being transferred in between offices because we're sending them with the referral. And then the general practitioner will provide the anesthetic, the sutures, and the gauze, and the oral surgeon will go ahead and do all of the bone grafting material, and then also the membranes and mostly oral surgery type of supplies. So if we just go through the oral patient, the flow here, the oral surgery coordinator will maintain that list for all future oral surgery dates on the specialist schedule that we can access through the office access. The oral surgery coordinator will create the standardized blocks on the oral surgery day, and then the oral surgery appointment types are to be used by the referring general practitioner, and the general practitioner will go ahead and put in the appropriate appointment note showing what time the patient prefers and what exactly is being done. And then all the referring offices will use the provider referral form on the website, and they will attach the new patient forms or the most recent x-rays or the most recent x-rays, usually the panoramic x-ray. The oral surgery coordinator will then confirm the diagnosis, and they will correct any codes for extractions that might not be perfectly correct or incomplete. They will then make the 14-day confirmation calls, and they will be dragging all of the appointments over to the side and then starting to build their schedule. Okay, they will use the same confirmation status as the general practitioner offices with the hygiene appointments that are out 1 month, which is basically they'll use the other confirmation status or the sent email confirmation status. The oral surgery coordinator will then make their 7-day and 3-day confirmation calls. They will only put patients on the schedule that are confirmed. And then all of the administrative work, such as the pre-op instructions and the prescriptions, will be completed before the oral surgery or surgeon is called into the room. And then the assistant will have all of the panoramic x-ray ready for the oral surgeon to go ahead and inspect. So the oral surgeon will confirm the diagnosis and then walk out the particular procedures. Again, pathology, irregular medical history, or irregular patient behavior, or special needs should be considered as a referral to a dedicated oral surgery office. The oral surgeon will sign or designate to be signed electronically all the prescriptions before beginning the procedure. 2 assistants will be in the room for the sedation procedures and also to satisfy the sedation requirements. There is the ability of Paradex, amoxicillin, and clindamycin to be made available in the general practitioner offices, and if the general practitioners do want that to be available, then the codes of Perry, amoxicillin, or clindamycin will be used as the walkout. The oral surgery assistants will provide the oral surgeon with a list of names and phone numbers of all patients that are needed the oral surgery, or basically the post-op calls after, they'll provide it to the oral surgeon before the oral surgeon leaves the office. And then the oral surgery coordinator will send out all oral surgery claims, and it's usually done by the next business day. And then all rejected claims will be assigned to the oral surgery coordinator for follow-up. So again, if you have any questions, reach out to the oral surgery coordinator, or look at the referring to open affordable oral surgery in the doctor manual, and that should clear up all of your questions.